but diverticular disease is the main cause of lower GI bleeding. So we have added into this lower GI bleeding as well. What are the causes of lower GI bleeding, and specifically dealing with these later on. So first we understand the lower GI bleeding. So so that is objective is summarize the recommended management of lower gastrointestinal bleeding. Hmm? Outline the typical presentation for a patient with lower gastrointestinal bleeding. So, what are the management system and what is the presentation of different causes of the GI bleeding, lower GI bleeding, and review and what are the pathophysiology of this bleeding, and explain the interprofessional team strategies for improving care coordination and communication regarding the management of patients with lower GI bleeding. So, any bleeding that occurs distal to the ligament of treats is lower GI bleeding. Ligamentum trees is attached to the at the junction. It's a fibro is attached to the at the junction. I mean pre like luminal part of or anti-mesenteric part of the lumen is attached and attached to the wall of the abdomen. So it's a ligament of Teres. This is the cutoff point. So duodenojejunal junction. In other way, duodenojejunal function. So duodenum and proximal upper GI bleeding and jejunum and distal lower GI bleeding. Right. This condition range from scant bleeding to a massive hemorrhage. So bleeding can be very small in amount and it can be very massive. So, but there is some issue that in lower GI bleeding, we say the color will be blackish, like tarry black and sticky stool. That is called melinum. But it depends. Upper GI bleeding, tarry dark stool and sticky stool, it presents as melina, which is of upper GI bleeding. But it depends. Usually, upper GI bleeding, we talk about cancer of the stomach, which is bleeding, ulcer of the stomach, which is bleeding, ulcer of the duodenum, which is bleeding, a small amount. So it will present at the form of melena. If it is too big, like in esophageal varices, like in posterior duodenal ulcer, which has penetrated the gastroduodenal branch of the gastroduodenal artery and which is bleeding, there will be too much bleeding. So too much blood into the stomach will lead to the hematemesis. MSS and hematemesis will induce MSS, and along with MSS, along with the vomiting part, there is a blood. We call it hematemesis. So it's a too big, too massive hematemesis will lead to the too much blood into the gut distally as well. So you may have fresh blood into the stool, which is from the upper GI bleeding. This is some sort of paradox. Like too much bleeding, it will behave like a lower GI bleeding. So don't confuse it with the lower GI bleeding because you know that there is a hematemesis as well. So it is originating from the upper GI. So, anyways, usually what happens, upper GI bleeding presents like melena, and the lower GI bleeding presents like a fresh blood, bright red blood, or like too much blood. But it again depends. The If you talk about jejunum, ileum, which is again lower GI, right, bleeding, they may be present like melena, or even ascending colon bleeding or cecal bleeding may present as melena, and colorectal bleeding and distal uh, the descending colon bleeding may present as fresh blood. So it depends how much distance has been traversed by the blood, and that chemical changes occurs, and you find melena or otherwise fresh blood. So lower GI bleeding can be categorized further into three types. Massive lower GI bleeds are mostly due to diverticulosis and angiodysplasia, right? So we have divided like different diseases. in which we have massive, in which we have moderate bleeding, in which we have occult lower GI bleeding. So I was talking about you occult lower GI bleeding, like no blood, microscopically you find, and these are the inflammatory, neoplastic, and congenital causes. But diverticulosis and angioplastia, they may present as a massive bleeding, and less massive, we call it moderate, occurs at any age and presents at hematochezia. Or hematochezia means fresh, bright red. Melena means like dark, tarry, and sticky stool. So in this moderate bleeding, we have differential diagnosis of neoplastic disease, inflammatory, infectious diseases, benign, anorectal, and congenital. Anorectal means hemorrhoids and fissure, benign anorectal and congenital. So you depending on the, it is not always true that diverticulosis will lead to the massive bleeding, but it may bleed very small in amount. So, but commonly the diverticulosis leads to the massive bleeding. Angiodysplasia will lead to the massive bleeding. Even carcinoma colon, like neoplastic carcinoma colon, may present with massive bleeding. But usually they are occult bleeding at the time of the presentation or initial research, depending on the con- progression of the disease at the stage of the disease. Are you with me? Yes, you guys are with me.
Yes, doctor. Yes, we
Okay,
are here.
good, good, good. So, epidemiology, lower GI bleed is fairly common and accounts for 20 to 30% of all patients presenting with major GI bleeding. The incidence is higher in older patients and patients taking multiple medications or multipharmacy. Multipharmacy, like especially NSAIDs. In old people, they have arthritis, osteoarthritis, and other inflammatory conditions which may lead to the pain. And because of the pain, we take NSAIDs, and NSAIDs can induce bleeding. So they may present like this, or multiple medications like defect the coagulation mechanism, and that's may lead to the bleeding. So lower GI bleeding, if you compare the upper GI bleeding and lower GI bleeding, which is common, the upper GI bleeding is common, right? But it is fairly common. Lower GI bleeding, 20 to 30% all patients with major GI bleeding. 80 to 85% of GI bleeding originate distal to the ileocecal valve. Although the origin of classically or theoretically, the origin starts from the jejunum for the purpose of the bleeding, lower GI or upper GI, right? But 80 to 85% bleeds originate distal to the ileocecal valve, like cecum, colon, sigma, ascending colon, transverse colon, descending colon, and colorectal. With only 0.7 to 9% origin from the small intestine. The small intestine bleeds very rarely. The remaining causes usually begin in the upper GI tract. So most of the upper GI, these patients, these are the upper GI tract which are bleeding and causing and presents in the lower GI. So carcinoma stomach can bleed, peptic ulcer can bleed. These patients usually present with brisk bleeding, melena, or bright red blood per rectum. Depending on the small amount, will be melena. Bigger amount may present as bright red blood per rectum. And too much amount of the blood which is in the stomach or in the duodenum, it will induce emesis, and emesis will lead to hematemesis because in the contents are blood, so it will lead to the hematemesis. So usually, if you see bright red blood into per rectum because of the upper GI tract, you will have hematemesis as well. So you can differentiate that it is a upper GI bleed or lower GI bleed. Pathophysiology of different diseases which cause lower GI bleed. Diverticular disease accounts for over 40%, present as painless hematochezia. So painless hematochezia may occur in diverticulosis. Painless hematochezia may occur with angiodysplasia. Painless hematochezia may occur with colorectal cancer. So it is not only the diverticular disease, but we are talking about regarding diverticular disease, they present as a painless hematochezia. Hematochezia means fresh, bright red blood per rectum. More than 80% stop spontaneously. This is fortunate. Mortality, still mortality is 2 to 4%. Diverticular bleeding usually recurs on and off, commonly in elderly. You know that we will discuss all about diverticular disease commonly in elderly. Causes a chronic constipation and altered colonic mortality. So that constipation, which is because of the Western diet, and that causes forceful contraction, and they will produce diverticuli, and then they may bleed. We'll discuss in detail about diverticular disease. One third with the presumed lower GI bleed and heavy bleeding will have an upper GI bleed, as I've told you before, right? Peptic ulcer disease and recent NSAID use. More pathophysiology, ischemic colitis may present with bleeding. Ischemia, so necrosis occurs and they may bleed. Most common cause of low GI bleed in patients younger than 50 is anorectal disorder. So, in more than 50 years, majority of the patient they present with the lower GI bleeding. They may present with the colorectal cancer, with diverticular disease, but less than 50, usually benign conditions, and they are anorectal, hemorrhoids, and fissure. Inflammatory bowel disease, inflammatory bowel disease usually bloody diarrhea. So you have a like fecal content with a blood, but they may bleed isolation without fecal content as well. But majority of them, most of the time, they bleed with fecal content. And NSAID use is always can cause ulceration and can cause bleed. So how do you take history? You know that when we talk about differential diagnosis, so differential diagnosis would be many: inflammatory process, cancer process, diverticulosis, angiodysplasias, pathological coagulation process. So you know the so when we talk about the most common cosmology of diverticular condition, yes, colorectal as well, colorectal carcinoma as well. So you talk about history, you will get history. You may not get history, whole history, but you can ask certain questions which may tell you or give leading points that your whatever you have in your mind, the differential diagnosis. So history of gastric and peptic ulcer, gastric duodenal esophageal ulcer, which is peptic ulcer. If there is a history, then you can. The history means pain, and usually it progresses. Usually it presents with pain, postprandial pain and without pain, heartburn, and then they may become disease progresses and they may bleed. So if you patient comes to you with the bleeding, then you can ask about peptic ulcer disease or Mallory Weiss-Steer. Mallory Weiss-Steer with it is forceful retching, actually forceful vomiting with retching. Retching means you attempt to vomit forcefully with all abdominal muscles being contracted, but you don't get vomiting out. This is called retching. Ineffectual, forceful contraction of the abdominal muscles for emesis, but you don't get emesis. This is called retching. So just after eating, I mean, too much eating, after too much eating, you're full of your stomach is full of food and it is distended and then retching occurs, it may tears esophagus, it may tears esophagogastric junctions, and you may bleed. So this is there will be hematemesis, there will be too much bleeding. That is why you have hematochezia, bright red blood per rectum. Recent weight loss, then ulcer and malignancy. And you have cirrhosis, alcohol history, hepatitis C infection history, or interferon taking history, or all the stigmata of this liver stigmata regarding cirrhosis. So this will lead to the variceal formation, esophageal varices, and that may cause bleed very easily. So cirrhosis, heartburn, and reflux because of the GERD. Past surgical history, including any abdominal surgeries and endoscopies, should be obtained. So you may have different past histories, current histories, peptic ulcer histories, carcinoma stomach histories, colorectal cancer histories, or constipation and diverticulosis. So history is important to understand. Review medications, in particular NSAIDs. You know that NSAIDs may cause bleeding, and steroids can cause ulcer formation. You have ulcer in the head injury, multiple erosions in the stomach. We call them Cushingoid ulcers. And the burn setup, they're again curling ulcers. There are multiple erosions. NSAID use, multiple erosion, stress, hypovolemia, they may all lead to the such type of the multiple erosions in the stomach, and they may bleed easily. Obtain relevant family history, including colon cancer, inflammatory bowel disease, and GI malignancy, because they may be cause of the bleeding. Any social history should include current and post alcohol consumption and smoking status. Alcohol may lead to cirrhosis, cirrhosis may lead to the variceal formation, and they may will be hematemesis. Additionally, sick contacts and recent travel outside of the country should be elicited. They may lead to the like such things like which may lead to the cirrhosis formation. How do you examine such patients? Multiple causes, multiple findings. If you know the cause, you know the how gastric ulcer may present, how carcinoma colon may present, how an inflammatory bowel disease can present, and how cirrhotic patients can present. If you know, then you will ask questions and history, and you will come to know the cause of the bleeding. So physical examination, I told you, that evaluation and resuscitation, they go side by side concomitantly, because you cannot wait for evaluation and reach to the diagnosis and then do you resuscitate. Because if you don't resuscitate and you waste time on evaluation for diagnosing, you may lose the patient because of the bleeding. So you should have vital signs, right? Like pulse, blood pressure, temperature, and respiratory rate. If it is vital signs are normal, then you will be comfortable that okay, patient is stable. There is no hurry. There is no emergency, and vital signs will be disturbed. Then because of the hemodynamic instability, you will have tachycardia and hypotension, which cause urgent situation. Keep in mind, older patients on beta blockage may not be able to mount tachycardia response to a massive GI bleeding. So somebody who is already on beta blocker for hypertension or for some other diseases, if somebody is already on beta blocker, so tachycardia response because of the bleeding will not be that much. So they may give you false sense of security that there is no much tachycardia, so he is not bleeding. But if you know that he is taking beta blocker, then tachycardia will not be that much in spite of the bleeding, in spite of the shock, in fact. So resuscitation should begin immediately for unstable patients with further history and examination is completed. So, as I told you, in emergency we do ABCD, right? And along with that, we do evaluation and resuscitation concomitantly. Always look for signs of anemia or dehydration, including pallor, lethargy, and mucous membrane, skin tenting, flat neck veins. So, if you find a history of, signs of dehydration, this is a feature of shock. The patient has bled too much. He requires or she requires resuscitation. More physical examination. A thorough abdominal examination should be performed to locate any tenderness, rebound guarding, or sign of peritonitis, because there may be a bleeding inside the after trauma or because of any reason. Pay attention to signs of cirrhosis, as we have discussed, including spider, angiomata, spider nevi, prominent abdominal veins, capillary and ascites. So you'll think that the hematemesis is because of this, and lower GI bleeding because of the hematemesis, because of the esophageal varices. A rectal exam is must be performed in patients with presenting the GI bleed in order to identify perineal causes. Sometimes hemorrhoids may bleed too much, may lead to shock even, which is rare. So you might think that something else is bleeding, and you don't examine the rectum and the perineal region, so you may miss the diagnosis. Perform an occult blood test at a time of rectal examination, and women include a pelvic examination too. So, occult blood test, like when somebody has got history of colorectal cancer, like altered bowel movement and pain in the abdomen, losing weight, so and the age of the see in more than this. So you suspect, you do screening, and in screening, fecal matter will have microscopic bleeding, which may be because of the colorectal cancer. You won't see grossly, right? It is microscopic. So you do GOAC test, which is for the occult blood, and which is we also call fecal occult blood test or GOAC test. So we send fecal matter, three consecutive specimen of the stool for 3 days, and we send it, and if they find blood, then we suspect colorectal cancer, and we do colonoscopy then. So you see how small bowel can bleed and how large bowel can bleed. As a whole, small bowel bleeding is rare, but it is possible. Meckel's diverticulum can bleed, Crohn's disease, regional ileitis, right? Ileum. Although it is part of the lower GI bleeding, Meckel's diverticulum is in ileum, Crohn's disease is in ileum, and I mean from mouth to anus. But usually it is ileum. We call it regional ileitis. Neoplasm are less common in small bowel, but more common in large bowel. Vascular malformation may occur in small bowel, large bowel both. So as I told you, small bowel starts from the jejunum, and it is part of the lower GI bleeding. Non-mucous diverticulum, mesenteric thrombosis, mesenteric ischemia, drug reactions, enteric infections like amoebiasis, Shigella dysentery, and polyps may bleed, but as a whole, rare. Yes, colon, neoplastic disease is quite common, polyps quite common, diverticular or diverticulosis, especially diverticular may present in the duodenum, may present in jejunum, may present in the ileum. But when we call it diverticulosis, usually we mean that many diverticula in the sigmoid colon. Why it occurs? Because of the chronic constipation, forceful contraction of the muscles of the colon, they may produce diverticula, and that diverticula may get infected, they may get bleed, they may get so they so here diverticulosis means sigmoid colon. Angiodysplasia may present in the small bowel, may present in the large bowel. Ulcerative colitis, you know that it is colitis, and infectious diarrhea, maybe Shigella, maybe protozoa infection, amoebiasis. Rectum proctitis simple. Hemorrhoids and fissure, hemorrhoids bleed copious amount of blood bleeding, but usually it does not lead to the anemia if acutely present. If chronic, then can lead to anemia. It can produce huge, massive bleeding sometimes, but rarely. Fissure, just you get bright red blood, hematochezia. It doesn't cause anemia. It doesn't cause like too much amount of the blood through the lower GI bleeding as lower GI bleeding, but drop, like it doesn't cause anemia. So pathology within the small bowel accounts 10 to 15% of your lower GI bleeding, right? And small bowel bleeds are most difficult to locate and diagnosis. Why? Why? Because upper GI endoscope can see esophagus, stomach, duodenum. Lower GI endoscopy can see anus till cecum. So you are not able to see jejunum to ileum. We have different procedure, enteroclysis or biopsy endoscopy, like capsule endoscopy. So, and expertise is lacking and facilities are lacking. So bleeding through the small bowel is difficult to diagnose because you cannot see. Yeah, you can see through the barium follow through, but barium follow through, we don't do barium follow through. And if a barium follow through in case of bleeding, but we can do another test, technetium labeled tag RBCs, and with that we can tell you about bleeding from the small bowel. But as a whole, it is difficult and it is rare as well. So, as a whole differential diagnosis, annular abscess, like some amount of the reddish discoloration that may lead to the hematochezia, colitis, that, colon cancer, polyp, Crohn's disease. The inflammatory bowel disease, Crohn's, and the ulcerative colitis, usually fecal mixed with feces, but they may be isolated without feces. Diverticulitis, the diverticulosis. Diverticulosis means just presence of the diverticula in the segment colon. We call it diverticulosis. They can be asymptomatic. They can be symptomatic. When they become symptomatic, they may cause dragging sensation, pain, and they become infected. We call them diverticulitis. Even endometriosis sometimes, ectopic endometriosis. Intersusception in children may present as a hematochezia and Meckel's diverticulum. You know that. So evaluation, we have a criteria, bleed criteria. This is for the sake of convenience. We have a acronym which is bleed, and as it is bleeding, it is easy to remember. The bleed criteria are able to apply to any patient with GI bleed, upper or lower, and easy to remember. As I told you, bleed acronym. The criteria are listed below. Ongoing bleeding, red bloody emesis. Ongoing bleeding will be hematemesis. Ng aspiration will be bloody, and spontaneous passage of red or maroon blood. If a small amount is coming, it will be maroon. If a large amount is coming, it will be red. Systolic blood pressure will be low. You see, bleeding is there, ongoing bleeding, low systolic blood pressure. It tells you that a response of the body to the hypovolemia, tachycardia, and the low blood pressure, hypotension. Prothrombin time will be elevated because of the dilutional issue. And erratic mental status because of the oxygen defective saturation, your supply to the brain is disturbed, so you have an erratic mental status like abnormal behavior, confusion in your thinking. So this, if you see such patients which is bleeding, pressure is low, and prothrombin time is high, and confusion, so you say he is bleeding. And there is unstable comorbid disease like hypertension is not controlled, diabetes is not controlled, and infective diseases are there, other systemic diseases, medical diseases which are not under a stable condition. So if you find such patients, they require ICU admission. Why we go for ICU admission? Because in the ward setup, in the room setup, no nurse is there available all the time. All the parameters, multi parameters are not there. Other emergency measures cannot be done easily. So you keep patients in ICU. So one patient, one nurse, or two patient, one nurse in a room, and there's a multi parameters there, which all the time tells you all the vital signs, and ECG monitoring is going on. So so you become very cautious, and you monitor all the time patients, and you try to resuscitate the patient, and you see how resuscitation is progressing. It is improving or it is deteriorating. So it is part of the bleed criteria is for the evaluation. So other part of the evaluation, active ongoing upper GI bleeding was defined as red blood by emesis, like hematemesis, or in the NG tube, blood comes. It is a part of the hematemesis. While coffee ground, not considered active bleeding because becomes coffee ground in color when it is present for longer period in the stomach. And when you pass NG tube and you aspirate the NG tube and you find coffee ground color of the secretions which are coming out through the NG tube, you say he has bled already, but bleeding is not ongoing. If it is red blood, then you say ongoing bleeding. He is bleeding still. So so if somebody is bleeding still, even after resuscitation, like crystalloid solution, and the even giving a transfusion of the blood, it means bleeding has not stopped. So our aim is here to restore blood pressure by giving blood and by stopping blood. If you go on giving blood and you don't stop bleeding, what will happen? It will it will drop, blood pressure will drop down again. You give blood, again will drop down, so it is of no use. So stoppage and resuscitation, they go side by side. For the stoppage, what we will do, we will discuss. Active lower GI bleeding was considered the presence of a spontaneous passage of red blood maroon from the rectum, while formed maroon or black stool was not considered to represent active blood, right? Again, same philosophical view. So, treatment, as we are talking about lower GI bleeding, not talking about upper GI bleeding. So, if because of the upper GI bleeding we have lower GI bleeding, so we will do gastroscopy, upper GI endoscopy, and we do therapeutic procedures to colonoscopy. But here we are talking about lower GI bleeding, so we do colonoscopy, which can see from anus to cecum whatever is going on. If you can see through colonoscope, you can use injection of the adrenaline, you can do thermal therapy and you coagulation therapy, and you can stop bleeding. Or you can do CT angiography. So CT angiography tells you the bleeding point is where. You can localize it and can easily do through colonoscopy, therapeutic colonoscopic procedure, and you can stop bleeding, which is called hemostasis. Or if blood is very less and you cannot locate through colonoscopy or CT angiography, then you do technetium based tracer to red blood cells. And if it is also not possible, then we do surgery and we see which part is bleeding and we do resection of that part, and it can lead to the subtotal colectomy and will lead to the shortcut syndrome. So it depends. You start with the initial stages: colonoscopy, CT angiography, technetium based tracer to tag red blood cells. And if then you cannot localize bleeding, you cannot do therapeutic procedures through colonoscopic procedures or by angiographic procedures, you do surgery. And you can, in the surgery, you have done already CT angiography, you can see at least from where bleeding is coming, so that bigger part can be resected and make anastomosis. That may lead to the, not necessarily always you do subtotal colectomy. You can do segmental, a small piece of the colon, but it may lead to the subtotal colectomy and will lead to the short gut syndrome. Patients with lower GI bleeding usually present in the emergency department. You know that upper GI, lower GI, both emergency department. You do ABCD, ABCD, EFG. And because of the many differential diagnosis, an interprofessional team is required that includes a surgeon looking at if if bleeding is from the peptic ulcer, posterior duodenal ulcer, which has penetrated the vasa branch of the gastroduodenal artery and is bleeding. Usually, it cannot be controlled by endoscopy. Then you have to require laparotomy. Then you require surgeon. Gastroenterologist first will try and do endoscopic therapeutic procedure. If it is not possible, then surgeon will take care. Radiologist, interventional radiology. You can feeding artery can be embolized, and interventions, and you like emergency medicine specialist. They may require ICU admission. We have discussed earlier, and evaluation and resuscitation go side by side. The outcome of the patient with low GI bleeding depends on the age of the patient. Yeah, advanced age, the prognosis is bad. Other comorbidity, usually, advanced age, we have comorbidities, usually, and hemodynamic stability and need for emergent surgery. So, emergency surgery requires in the advanced age, prognosis will be bad. So, outcome of the patient depends whether patient was in advanced age, patient was having comorbidity, or patient has hemodynamic instability, and it requires emergency surgery. So all these things are for bad prognosis. Outcome means prognosis. So if these conditions are there, the prognosis is not good. If these conditions are not there, then prognosis will be relatively better. So this is all about lower GI bleeding. What are the causes of the lower GI bleeding? How do you take history of the lower GI bleeding? How do you investigate and evaluate and do physical examination? And how do you manage? Now we go to the main topic, which is diverticular disease. So, so why? What is happening? Share file. What happened? It is written there. Hmm? Condition having diverticular in which many sac-like mucosal projections, we call them diverticular, develop in the large bowel, especially the sigmoid colon. And acute inflammation, if it occurs in the diverticulum, we call them diverticulitis. Otherwise, diverticular disease, or we call it diverticulosis. Are you are you with me?
Yes, doctor.
Okay. So just presence of diverticulosis. It can be symptomatic, it can be asymptomatic, right? Asymptomatic may progress and will cause complication. So what is pathophysiology? You see, figure shows you this is motility is disturbed, constipation is there, and less fiber diet habit like in Western diet. So forceful contraction occurs, and because of the forceful contractions, the muscles contract, right? And because of the forceful contraction, your submucosa and mucosa project through the serosa, not muscular layer. So they present like this, and they will have a lumen. If you see from after cut section, they will have lumen, but it is not containing muscular layer. So this is pseudo diverticula. If it contains muscular layer as well along with the submucosa and mucosa, then we call it true diverticula. So jejunal diverticula, duodenal diverticula, they're congenitally present and they're true diverticula. Meckel's diverticulum is true diverticulum. These are false diverticula and they are present and because of the forceful contraction. Commonly affect the sigmoid colon due to relative high pressure zone within the muscular sigmoid colon, higher amplitude contractions combined with constipated high fat content stool within the sigmoid lumen results in creation of these diverticula. Related to the retention of particular material within the diverticular sac. So what happens? Some fecal matter goes here, and they will it will becomes fickle. Water is absorbed and becomes solid, and solid fecal matter is called fecalith. So this may block the blood supply and may lead to ischemia. That will lead to the can lead to the bleeding, can lead to the infection, or can lead to the hole, and hole will go into another organ and will make fistula. So different fistula formation, infections, and bleeding may occur. These are the three main complications. Or it may lead to the obstruction because of the again stresses. So again, pathophysiology that's explaining diverticulitis. Protrusion occurs at the point where the nutrient or vasa recti penetrates through the musculus propria, break in the integrity of the colonic wall, compression or erosion occurs. They may lead to the bleeding, they may lead to the perforation. We discussed fast diverticular, true diverticular, right? And diverticulosis is a false diverticular. So involves only protrusion of the mucosa through the muscularis propria of the colon, most common. A sac-like herniation of the entire bowel wall, as I told you, jejunal diverticular, duodenal diverticulum, and Meckel's diverticulum. So mucosa protrude through the
Doctor,
muscles. Yes.
the slides are not changing to us. You are on slide number what, doctor?
He can cancel. So now it's okay.
Change. Try to change it.
Is it okay?
Doctor, are you on the blackboard or are you on the screen itself? Your PowerPoint screen.
Now see.
No, nothing is changing.
Now,
Now it's changing.
yeah. So we discussed previous this point and now this point. This is okay. So false diverticular and true diverticular. So you see, just showing layers. What is happening? Serosa, muscularis layer, submucosa, and mucosa. The mucosa is projecting, may lead to some part of the submucosa, but not muscularis layer, and project into the touches the serosa. So they are false diverticulum. When you do colonoscopically, you will see small projections which has got lumen, and this is, you know, how the colon contract, how striations are there, segmental contracting. So it may lead to the forceful contraction and may lead to the mucosal projection. Example of proximal jejunal diverticulitis with perforation. Obviously, with the before the diagnosis, before the perforation, you won't be able to locate the jejunal diverticula. You will see when patient came to you with peritonitis, you will do laparotomy, and in the laparotomy you will see there is a perforation, and at the point of perforation there was diverticula and with inflammation, diverticulitis. So you cannot. It is like very difficult to diagnose the jejunal diverticula without symptoms, and usually symptoms will be diverticulitis. So there will be pain in the pain will be localization will be very poor, and you will not be able to understand where is the pain, and until unless you keep index of suspicion very high, so it may lead to perforation. Patient will come with the peritonitis, and when you do laparotomy you will come to know that what you see proximal jejunal diverticulitis. So pain will be there. So pain you will be you thinking like it is a peptic ulcer, but and you treat through the peptic ulcer, it won't be treated. If spontaneous treatment may occur, but if disease progresses, it will lead to perforation. So what exactly is diverticulum? The colonic diverticulum is actually not a true diverticulum, but rather a pseudo diverticulum. So it can be asymptomatic. You see, 70% are asymptomatic, and some can bleed, some can get infected. Infected, pain will be there, abdominal pain will be there, fever will be there, and 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 may bleed as well. So pain will be localization, like lower pain. You will obviously do ultrasound, and ultrasound may not tell you anything. Then you'll do CT scan. CT scan may tell you something. Then because there was a bleeding as well, you'll do colonoscopy, and in colonoscopy you will be easily see diverticular there, and they're bleeding or they're getting infected. Bleeding, obviously painless bleeding. So you do colonoscopy, you'll come to know if it infected, it will give you some confusion. But if it goes on, patient comes to you again and again, you will go for colonoscopy, you'll see something. So it may be simple, only infection, only inflammation, only pain and constipation, nothing else. This is 75%. Or it can get complicated, like a small perforation may occur, localization of the pus occur, infection occurs, and will lead to the abscess formation. Or it may lead to the obstruction because of the accumulation. Or it may lead to the perforation of fecal matter into the peritoneal cavity. It will be peritonitis. So abscess, there will be fever with rigor, abdominal pain, and a history of constipation, and abdominal pain will be localization on the left lower quadrant. You will do ultrasound and CT scan, and ultimately you will do colonoscopy. You will come to know that it was abscess. You will do ultrasound guided incisional drainage of the abscess by aspiration, and give antibiotic, and may get resolved. or it may lead to obstruction. Then you have to do like distension of the abdomen, pain in abdomen, nausea, vomiting, and constipation. Then you have to operate. It may lead to perforation and then can lead to the peritonitis. Again, you have to perform laparotomy. It may lead to fistula formation, fistula into the bladder. Bladder is nearby sigmoid colon. So we call it colovesical fistula. It may lead to in a fistula in the vagina if it is in the female, the colovaginal fistula. It may lead to because ileal loops are surrounding structures. It may adhere to the intestine because of the inflammation and may lead to formation into the ileum and may lead to coloileal fistula, or it may lead to the formation of the other colon, colocolal fistula. So it may get and enter into anywhere around the adjacent structure and will lead to colovesical, colocolal, coloileal, rectal fistula, and this way, not colovaginal fistula, actually, not colorectal, colocolal, coloanal, and coloileal, mainly colovesical and colovaginal fistula. Mainly these two fistula they form. So how they present? If it is colovesical fistula, like bladder communicated with the colon, how it will present? There will be a recurrent cystitis, burning micturition, and there will be a pneumaturia. Pneumaturia means patient will go for urination, patient will urinate, and after some times it will stop, and then again urine, stop and urine. The stop is a filling defect actually, which is the air bubble. So you it will present as a stoppage of the urine stream will be stopped and then suddenly stop, then suddenly start. So for a very fraction of second, and that stoppage is nothing but the air bubble which comes out. You don't see it. So this is called pneumaturia. And colovaginal, and without knowing of the patient through the vagina, you may have fecal matter. This is colovaginal fistula. So that the different presentation. Coloileal and colocolal, they may lead to diarrhea formation. Diarrhea again and again, even after treatment. So this may present in different way. Asymptomatic, bleeding, infection, or they can get complicated. So you have to deal with the complication. You see, it is a colonoscopic picture. So you see projection, you are in the lumen, and in the wall of the lumen, in the wall of the colon, you have another lumen which is blind. So and it is an usually you are doing colonoscopy for some other reason, and you find diverticular. As I told you, they are 75% they are asymptomatic, so you may find them incidentally. You see, this is air contrast enema, barium air contrast enema, double contrast enema, in which we push air and then barium sulfate. We see these projections. This is for more good resolution. We do double contrast enema, air plus barium sulfate. So you see projections, multiple projections in the sigmoid colon. So obviously, you keep suspicion of index high and you make differential diagnosis. One of the differential your main diverticular, so you'll do all these investigations and you may find something while investigating. You see, in the diverticular, fecal matter has accumulated and it will cause pressure and will make a fecalith and will pressurize the wall of the diverticula and will lead to the infection and the ischemia and may erode the vessels and can lead to the bleeding. So micro or macroscopic perforation of the diverticulum, subclinical inflammation to generalized peritonitis. See, previously thought to be due to fecaliths causing increased diverticular pressure. This is really rare, right? You see, colovesical, colovaginal. So you see, This may present fistula formation around surrounding adjacent structures. That can be ileum, that can be colon, that can be bladder, that can be vagina. So you may find, and there's presentation, and we discuss those presentation. They may bleed, as we and bleed like painless bleeding. Vasa recta is there in the wall of the diverticula, and pressure occurs, and they may bleed. You see, bleeding is a colonoscopic presentation of bleeding. You will see blood trickling down. Again, bleeding imaging, and he is doing therapeutic procedure, coagulating through by endoscope. Coagulating. There's a probe. You can do laser, thermal therapy, or coagulating procedure. These are electrical diathermies, bipolar diathermies can use, and we can stop bleeding. And there is a danger of perforation. While if somebody is junior or not expert and not be meticulous, it can cause perforation because you are going mucosa, because they are thin wall diverticula as compared to the colonic wall. So theoretically, more common in female, right? Age 50s and onwards. High incidence Western world because low fiber diet. But nowadays, I think globally diet has become same. But it is a still in the book it is written the Western diet is that, and in the Western world they take low fiber diet. But this is not so. But fortunately, in our part of the world, we take diet which is full of fiber and cereals and vegetables, so we don't have much issue of constipation. The Western world has most. It's common. Is more common in Western world. As you know, that inflammatory bowel disease is also more common in Western world, not in our part of the world. It is not. I mean, rare like in our part of the world, but as when you compare the Western world and our part of the world, it is more common in the Western world. Etiology we have discussed, right? Pathology, sigmoid colon emerge between the tinea coli and may contain fecalith. Histology, projections are a quad diverticula as they contain only mucosa, submucosa and serosa, right? No muscular layer, all layer of intestine wall. So only muscular layer is being omitted. Otherwise, all the layers, only mucosa, submucosa, and serosa. So clinical feature we have discussed, like mostly asymptomatic or present as pain, left iliac fossa pain, constipation, maybe diarrhea, alternating. So constipation is a pseudo diarrhea because of the is a pseudo diarrhea. Only pelvic collection and the irritation and only mucus secretion occurs. So it can be asymptomatic, only painful like tenderness in the left iliac fossa, or it may present as acute diverticulitis. If there is diverticulitis, there will be fever, there will be malaise, left iliac fossa pain, and tenderness, plus minus palpable mass and abdominal distension. So at this stage, we just treat constipation. We give painkiller and treat constipation, and usually things becomes okay. At this stage, we give antibiotic, painkiller, and relieving the constipation, life modification, so it will be okay. But if leads the peritonitis locally confined will lead to the abscess formation, or if it is becoming generalized, so you will have peritonitis. You have to open the abdomen and then do work accordingly. It may lead to the large bowel obstruction like absolute constipation, distension, colic abdominal pain, and vomiting. Then you have to operate laparotomy, or it may lead to fistula formation. We have discussed actually everything to the bladder, to the vagina, to the small intestine. So, coloileal, colovaginal, and colovesical. If it is colovesical, there will be cystitis and hematuria and recurrent urinary tract infections. Makes sense, right? Cystitis, burning maturation, maybe fever with rigors, and hematuria. If it is vagina, fe- vaginal fistula, then fecal discharge from vagina without knowing of the patient. If it is to the small intestine, coloileal fistula, it will cause diarrhea, irritation in the small intestine. Irritation will lead to an increased peristalsis and will lead to diarrhea. It may lead to bleeding, main, which is painless, spontaneous. Spontaneous, painless, without feces. Without feces, then you have to differentiate with the angiodysplasia. Yeah, they also bleed without fecal matter. So, clinical feature depending on the level of the disease and fistula formation, right? Investigation, you do colonoscopy, you do CT scan, and that's it. Two things can be easily tells you what it is. So colonoscopy, barium enema, you know, if you don't have colonoscopy, then barium enema. Otherwise, colonoscopy way better than barium enema because it is not only diagnostic, it is also therapeutic and more resolution. So CT scan will tell you the abscess is there, if it is perforation is there, or obstruction is there, and colonoscopy will exclude colorectal cancer if it is, and they will tell you colovesical fistula. So you have midstream urine and cystoscopy, colovaginal fistula, colposcopy. So you see a hemorrhage, then you do colonoscopy. Where it is, you will do therapeutic procedure through colonoscopy, or if it is difficult, then you do selective angiography and embolization through interventional radiologist, or there can be stricture formation. If a stricture formation in the diverticulum, better to do biopsy because it may lead to cancer formation. Diverticular stricture should be biopsied in case of underlying. So actually, colonic cancer will be concomitantly present. As you know, the colorectal cancer is common in after 60, and diverticular disease is also common after 60, and there is a chronic irritation and bleeding is there. So you have already made differential diagnosis of the diverticular disease and colorectal cancer. So always keep index of suspicion high for these things. Management. I told you before, painful or asymptomatic, just relieve the constipation, nothing else. High fiber diet, which is fruit, vegetable, whole meal, bread, bran, like this. And even jogging and walking, mobility, good mobility. So they will lead to the relief of the constipation, and you will have just a regression of the diverticular, and you will have no symptoms then. If it is acute diverticulitis, I told you, antibiotic, and if it is pus formation, drainage. So majority of acute attacks are resolved by non-surgical treatment. Antibiotic and bowel rest, NPO, right? Bowel rest means NPO, radiologically guided drainage of localized abscess. And then surgical treatment for obstruction, for peritonitis. Elective surgery should be reserved for recurrent proven symptoms and complication, for example, a stricture which leads to the obstruction, and peritonitis, then you do laparotomy, and then you have to resect an anastomosis, primary anastomosis. Emergency, which is common. This is difficult. Surgical elective cases usually being treated medically and very uncommon for elective cases. If it is elective, then you can do resection of the colon, which is containing diverticula, and make anastomosis. But if it is you are doing, because why we are doing anastomosis, primary anastomosis? Because the case is elective. You have prepared the gut. Preparation of the gut means you have given low apparent diet, juices only, no stool formation, and you give like laxatives, and you give cleansing enema, and then you clear the sigmoid colon and the large intestine without stool. You it is now without stool because you have cleared all these things. The fecal matter has gone out. In the presence of fecal matter, if you do anastomosis, there is a chances of leakage is not being good enough, and it will leak. Repair will leak, and there will be again peritonitis. So when we do elective cases, we always prepare the gut, because we know that we have to do resection and anastomosis. And if it is an emergency, like an obstruction, patient will come in emergency. The fecal matter will be, the sigmoid colon and the descending colon will be full of fecal matter. When you resect it, so you will not do anastomosis here, right? What you do Hartmann procedure. Hartmann procedure, distal portion will be stitched, sewed, and proximal portion will make as a fistula and colostomy, which is descending colon and colostomy, which is temporary. And this is two stage procedure, Hartmann procedure. Hartmann procedure, in the face of fecal matter which is present there, and if you repair it, do primary anastomosis, it will leak. You don't want it to leak, so what will you do? You will do Hartmann procedure. Distal portion is being stretched, closed, and the proximal portion brought to the surface of the abdomen as a fistula, which is colostomy. And then after some times give antibiotic, painkiller, rest, and edema formation, edema is subsided. And then after, say about after 3 months, you do again operation and you make anastomosis between distal and proximal, and close the colostomy. This is emergency, right? Which I have discussed. Emergency surgery for complications has a high morbidity and mortality, and often involves an intestinal stoma. Intestinal stoma means colostomy. Emergency left colon surgery with diffuse peritonitis, resected disease segment. You resect disease segment, oversew distal bowel, mean close distal bowel, that is upper rectum, and bring out proximal bowel as an and colostomy. This is Hartmann procedure. So descending colon as an ankylostommy, and the rectum, which is the distal part, which is being closed by oversew, and in this way, one stage is being completed. And after some time, you do again this procedure and close the rectum with the descending colon and close the colostomy. Emergency left colon surgery with limited or no peritonitis, you do resection of the disease segment and rejoining the head. So, like, infection is not that much, fecal matter is not that much, then you can do primary anastomosis. Otherwise, better to do Hartmann procedure, and it is a safe procedure compared to the primary anastomosis because it can leak. So, complicated left colon surgery, for example, colovesical fistula. So, you do resection and primary anastomosis. So you do what? You resect the tract, you close the primarily sigmoid colon, then close primarily bladder wall, right? And you do proximally colostomy, loop colostomy. We call it defunctional proximal stoma formation or loop colostomy, because we have repaired the bladder, we have repaired the sigmoid colon, primarily hole has been repaired because there was a hole in the sigmoid colon, hole in the bladder, and they make tract. We excise the tract and repair the hole by freshing the by refashioning the margins, or by excise the necrotic tissue of the margins, hole become bigger in the bladder, hole become bladder in the sigmoid colon, we primarily repair it. And if we do not do defunctional colostomy, fecal matter will come in contact with the repair part, and they will cause infection and repair may leak. So that is why we do defunctional colostomy, and that can be closed after like a month that repair has been done. So you see, this way you treat diverticula, whether it's asymptomatic nature with symptomatic nature at the level of the diverticulitis, at the level of the perforation, at the level of the obstruction, and at the level of the fistula formation. So different uh, level of the stages of the disease and different treatment. So as a whole, diverticulitis or diverticular disease is a benign condition, but there is a significant mortality because of the complication and morbidity. Because, right? So this is all about your diverticular disease, which is the main, which is also the cause of the lower GI hemorrhage. If you see lower GI hemorrhage, you will do colonoscopy, you will do like accordingly a treatment of the bleeding, like colonoscopic procedures, coagulating procedures. Usually you can control the bleeding, but you know that now you know that after colonoscopy the diverticular, if they are once has, they have bleed as well. So you will treat the cause by life modification, and you will follow the patient. You will do again colonoscopy. You see that even after life modification we don't see regression of the diverticula, so there are again chances of bleeding, infection in the fistula. So better to do electively resection of that part and anastomosis. So in this way, you will take care of the bleeding of the other causes of the lower GI bleeding, and specifically about whole about diverticular disease. So that is all about your lower GI bleeding and diverticular disease, right? So can we call it a day? Or now you have any question, any confusion, any anything?
Just doctor, about defunctioning colostomy or defunctional loop colostomy. What is it exactly? Again?
Yeah, defunction colostomy, like uh, there is obstruction, right? Or there is peritonitis, or there is an abscess formation because of the complication of the diverticular disease. You do laparotomy, or because of the fistula, colovesical or colovaginal, you do laparotomy, or you do whatever procedure. Fistula, for fistula you don't do laparotomy, but for other things you do laparotomy. You work on the colon and you repair it. So you don't want fecal matter to come in touch with that repair part. Whether you have done anastomosis, whether you have done primary repair, you don't want to touch the because if you do nothing, what will happen? Fecal matter will come down and will touch the repair part and will may cause infection, and infection will cause leakage. You don't want it, because again there will be peritonitis, so there will be too much problem. Again there will be patient will may enter into septicemia. So you don't want fecal matter to come in touch with that repair. That is why proximal to the repair part, you bring l- loop, descending colon loop at the surface, and you make hole that loop, and you make fix with this surface of the abdomen. So whole loop is being fixed proximal to the repair part. So fecal matter will come outside the body in the colostomy bag, right? It will be a loop colostomy, because it is not end colostomy. Whole loop has been taken to the surface of the abdomen. So fecal matter will go outside into the colostomy bag, and repair part, which is distal, will get rest and will start healing. And it will take around like 10 days or 20 days. And then you can do barium enema, or you can do colonoscopy, and you can see it has healed or not. If it has healed, then you will close the loop colostomy, and that's it. This is called defunction. Defunction means distal part is not functioning now. That is why we call it dysfunction. Defunctioning colostomy.
So it's kind of like Hartmann procedure.
No, it is not the Hartmann procedure. Hartmann procedure we do This is simple. This we do in the fistula. This we do when there is fistula, colovaginal and colovesical. Hartmann procedure, like there is an obstruction, a stricture formation because of the diverticular. Yeah, why there is? Uh, uh, so a stricture formation into the diverticular that lead to the obstruction. So now what is obstruction is an emergency. You will have all the feature distension in the abdomen, pain in the abdomen, nausea, vomiting, and constipation. So it is an emergency. So you will not have time to prepare the gut, like because your fecal matter cannot go out even by lavage and barium enema. It is obstructed. So you will work in the presence of fecal matter. So what you do, you know that this is a diverticuli which is causing obstruction. So you will cut that segment. And then, if you do primary repair at this moment in the face of the fecal matter, in the face of the peritonitis, they won't heal. What you do, distal segment, which is usually rectum, you close it, and the proximal segment, which is the end part of the descending colon, you brought to the surface. So your end part of the descending colon is being brought to the surface. So this is called end colostomy. This is Hartmann procedure, and that Hartmann procedure is being again second stage operation. You close, you do anastomosis. That infection is over, you have treatment, given treatment, edema has subsided. After, it takes about 3 months, maybe 2 months, right? 2 to 3 months. You will follow the patient, you will see symptoms has gone. Then you again open the abdomen, and then you bring down the end colostomy, and you open the lower end, which is rectum, which has been closed. You open them, you flush them by excising the margins, and then you close them. So this is complete. Your Hartmann procedure is closed. So this is Hartmann procedures, which where end part of the descending colon is being brought to the surface of the abdomen. And in fistula treatment, when you close primarily sigmoid colon and the bladder or vagina, you don't want the fecal matter to come down. You proximal to the repair, way beyond proximal to the repair part. You brought loop as a whole to the surface of the abdomen, and that is called loop colostomy. So you again close it, right?